keep this here. And do this. All right. Well, thank you very much. Just please state your name.
Laura Catanzaro,
Okay. Your age.
24.
All right. Years experience.
2 months. Graduate in December.
All right. Type of school you went to for PT.
Dual degree at Seton Hall University. 3.5-year program.
Gotcha. So 3.5 years in PT school.
Yes.
Correct. Okay. And that included your rotations.
Yes.
Gotcha. All right. Good. Thank you.
Mm-hmm.
All right. So, again, I'm going to ask you certain questions. I might follow up with the questions. If you have any questions about the question to clarify, I will definitely do that for you. All right. So, first question. Talk to me about your clinical readiness after your didactic curriculum.
So I felt like I was ready, definitely with documentation. I feel like we were over-prepared with documentation. We had a lot of assignments where...
Can you tell me how so?
So we had a lot of assignments and we had to write the full-on eval and everything. And we had to literally put every single little detail. Now, our assignments were like 12 pages long. Whereas now coming into the real world, I feel like it's not realistic as a PT. Not saying like to skip things, but I feel like we kind of went overboard. But in a way, it did help prepare us for good documentation because I have seen other therapists who don't write anything at all. So
Understandable.
I do feel very prepared. Definitely taking a subjective history in an eval. I feel like I can ask all the questions that I need. Objective, so based on the things that people tell me, I feel like I'm able to come up with at least an idea of what I'm going to test, like as in range of motion, muscle testing, and get a good idea of the special tests that I want to do off the bat. And then maybe depending on what I find, I could decide what else I want to do.
Hold on one second. Who are these people who are telling you?
What?
You said before that these people are telling you. Are they therapists?
Oh, patients.
Oh, patients. Okay.
So
never mind.
getting things from patients, what they're telling me, like their symptoms and whatever. So I didn't feel too ready when it came to complex cases. Yeah, we have case studies with them, but I feel like when you actually see the real patient, it kind of throws everything out the window and we're kind of like taken back and we're like, oh wow, like, what do we do? Especially when it's multiple body parts. I feel like we're not used to dealing with that.
So it's hard for you to. So basically, what you're saying is, in your didactic curriculum, they pretty much taught you more of the just textbook cases.
Yeah, I feel like it was more with that, and also we would touch base on complex cases, but I feel like maybe we should actually practice treating somebody like that. And then another thing is, we're all practicing on each other. We're all healthy, so it's weird and different to see something that's on a patient that, like, oh wow, like that's bad.
So practicing on a regular student who doesn't have any deficits was a lot different for you to perform during your clinical.
Definitely.
Okay. Continue.
Readiness. I felt like I was prepared based on my knowledge, like for the most part, except for maybe being under pressure. I felt like I was able to answer things that my CI would ask me. Maybe if it was like on spur of the moment, I would blank, but I would know the answer. So I felt ready with that. I don't know if you want me to wait until other questions.
Yeah, we're only going to do question one.
Okay.
And I have a follow-up question. So discuss or tell me more about your preparedness for your clinical rotations based upon you had to do like one orthopedic, one acute, and one subacute. Can you describe, was it different or was it similar prepared for each type of genre you had to go to?
So I feel like that depends on where you go. I didn't have an acute care just because of where we live. They couldn't find an afil for me, so I never had an acute care afil. My first one was ortho. I felt like I learned the general basic. I got to see Therex. That was another thing. Now I'm thinking about Therex. You learn the basic exercises in school, but I only know to give people things that I've seen. So now I'm seeing other therapists treat, and I could say, oh, that's a great exercise, and now I know how to give that to people, or I'm more creative.
So, just to reiterate, you were saying that whatever your CI was doing, you learned from that?
Yep,
Did
my
you-
CI or other therapists, like
Okay.
I was observant.
Gotcha. And now, did you understand the theory behind each exercise and the reason why they're doing it?
Yeah, I mean, I think it was just more like, in class we learned, for example, short arc quads, but then there's other things you can do besides that. So I think it was just more, I had my set exercises, but then when you go to clinic, you learn more, and then you learn what other therapists
Gotcha.
like.
So you're saying that you, in your TheraX classes and therapeutic interventions, that you only learned you got a taste
We
of
learned the
it,
we got a
basics, but
small
there was
taste.
so much else that you learned from the clinic.
I'm still learning
good.
more.
And that was just for your orthopedic clinic.
Yeah, for the orthopedic, because then I did, my first full time was a subacute.
Okay.
And
Subacute and acute were very
yeah,
similar.
so I mean, but those patients, they were pretty complex, but a lot of them couldn't really walk. And the same thing was my once a week one. It was in a geriatric home where nobody could walk, so it was really just, let's kick our legs out, let's do hip hikes, so it was very easy.
Okay. Just for the exercise component.
Yeah.
How about, did they prepare you for more of your clinical decision making for that acute care? And talk to me more about
So for that, I was a lot more nervous, especially I feel like bed mobility, yeah, we learn it in school, but when it came to somebody who's 300 pounds and can't move, I felt very nervous in the beginning on how to instruct them, because it's not in school we learn, okay, one step, roll over, put your hand here, pull yourself. Chances are those people can't do that in the clinic or in the subacute setting, so I guess just having to think outside the box on how to make it work for them instead of the cookie cutter way you learn in school, that was hard.
I understand, yes. So you're saying in school, again, practicing on your own students was a lot different
Or
than...
best case scenarios. Think about a person who was in bed or stuck in the hospital for 3 weeks. They just, I don't know, they had a heart attack or something, and then they've been immobile, and now you try to get them up for the first time. It's not going to be easy.
Not going to be easy, and basically you didn't get a chance to experience that.
Until my first day.
The first day,
yeah, and then, my CI's looking at me shouldn't you know this? And I was I've never seen this before,
Okay, that would be a follow-up question. Okay, that's very good, and that's very interesting. All right. Again, you just can you elaborate more on your preparedness that your school did for you?
They've made us very prepared when it came to red flags. I feel like if a patient was telling us, for example, I have back pain, I lost weight, I wake up in the night with pain, we have the general idea that that's not good. So we're able to, I think, detect red flags with the whole, and now that brings us back to the whole direct access thing. I feel decent with that. So I feel like they really harped on the red flag issue and when to refer and when
not to refer.
Yeah.
Is it only with the low back pain, or do you feel also too well prepared for some other red flags that they discussed?
I guess when it came to the skin and integument, when we learned that whole thing with the wounds and all that stuff. Yeah, I guess the spine. I think it was mainly cancerous type of red flags that they were worried about.
Okay.
Yeah.
Okay.
I guess yeah.
Good. All right, let's go to the second question. All right. So discuss your confidence level prior, all right, to going into your clinical rotations, and then how was it, during or after?
So my very first one, my ortho one, I was nervous as anything because I had no idea what to expect.
Okay.
The only thing that we had was 1 or 2 site visits where we went by ourselves, and the only thing I had to do was take a range of motion. So that was easy. So I was really nervous, but then, after discussing, so I watched in the beginning, And then once I was discussing things with my CI, he agreed with me, so that made me feel better.
Okay.
I knew what I was talking about.
Yep.
Or even, he would do an eval, and I would say to him, "Oh, it seems like shoulder impingement, based on I saw you do a Hawkins Kennedy or something." So then he would say, that's what I was thinking. So my confidence started to build with my clinical reasoning a bit.
Yep.
I think the more my clinical reasoning went up, even as time went on into my other fills, the higher my confidence went. I think it was just the initial, in the beginning. What else?
So how would you, if you had to rate your confidence level prior to going into your 3 clinics, let's base it on your first clinic, where would you rate yourself from 0 to 100%? Highest is 100% confident.
Right. I was probably like 25 because I didn't know anything. Like
Okay.
I had no idea what to expect on that
Okay.
first. But then as time went on, I felt really confident in that setting.
Okay.
But then again, I didn't have a full caseload. I was seeing maybe like 6-7 people a day, so I was like 100% confident, thinking, "Oh wow, like this is easy. I could do this." I wasn't doing intense notes like all that because it was only my first to fill.
Okay.
Second to fill was the subacute. I was like 0%. Like I was just really nervous because
Okay.
I always felt nervous about patients who were very acute or like very medically complex, or something can happen to them at any time. Whereas in ortho, it's not really the case. I mean, it could be once in a while. So I was very, very nervous going into that with the really like medically ill patients. As time went on, I realized it wasn't as bad as I thought it would be. I think also just being there, the patients that I had, like I was looking to see more, and I was kind of seeing the same types of patients there. Like over there, it was more people that went to the hospital for stomach pain, and then they're there. Like I was looking to see maybe amputations and other things like heart attacks. So I didn't really see a lot there. So it was very easy. So by the end of that, I was better. But in the beginning,
Okay. So what would you rate your confidence level after that?
I would say like 75% because I
Okay.
knew subacute wasn't really my thing.
Yeah.
So I was like,
So you probably had a little bias going in.
yeah, I did have bias going into that.
Did sorry to interrupt you, but did some of your other classmates feel the same way?
Oh yeah, there were people that were like, oh, I don't want to. Like some people hate ortho, and there's some people that, wanted to really try neuro, and then they were so open to doing it. And then like there were some people like I know I don't want to do peds. I never want to do peds. And so I was always biased against that, but then there were some people that loved peds and they enjoyed it. So we definitely had that going into it.
Okay. But did they kind of feel the same way with like their confidence level?
Yeah, I think so too. Like I had some friends in the acute care, and they were like still nervous every day based on the things that they were seeing. Like they were on the cancer unit and the stroke unit, so that was more intense. So they did feel the same way.
Gotcha. Okay. And then for your last affiliation.
So my last affiliation, now I could be a little biased too because I always wanted to work for Kessler.
Okay.
So I think, and then I knew, some of the people that worked, so I really wanted to make a good impression. So I was very nervous in the beginning. Plus I felt a little rusty from ortho because it was about like maybe 14 months since I had practiced ortho. So I was a tad bit rusty, but I was studying for the boards at that time.
Yeah.
So when it came to special testing, I was good. My confidence was still a little low until the end, after my CI told me you gotta get better with your confidence.
Okay.
But then as my clinical reasoning started to get better, I started to feel a lot better. I was seeing the way patients were tolerating my treatment. They were coming in, like people were requesting for me to work here. So I was like, hey, I have to be doing
So
well.
so that probably boosted your confidence too.
Yeah, so by the end I was good.
Good. And do you feel, so basically on average your confidence going into your clinical rotations after your didactic curriculum was maybe at 25%, and now where would you say at the end of
It moved to about like 80-85% just because I felt entry level. I didn't feel like I was ready to take on the universe and that I knew everything. I still felt like, all right, I have what I need to know to start, but I still need to grow.
I understand that, yeah. And that's something that, you're not supposed to know everything. I don't know everything.
Right.
I definitely don't know everything.
Yeah.
But the purpose of your didactic curriculum is to make sure you're safe.
Right.
Biggest thing, safety. All right. Second biggest thing is respect. Respect your your clients or patients, as respects of your employees and respective families. Yes, I think that the curriculum gives you that base of knowledge. All right, but sometimes I understand where some students get upset because they don't get that full on experience working in that clinic.
And it's also 3 months too. Like I was looking the longest time for an ACL patient, and we never really had one. So now I don't really know how to treat an ACL from start to finish because I never did. But it's not anybody's fault. We just didn't have any patients.
Okay.
You know what I mean? So I don't, right now with that, I don't feel confident.
Okay.
But
so you still don't feel confident, even though no matter, what your schooling did end with your.
Yeah, I mean, I guess it depends on what I learned in clinic too.
Gotcha. Okay. For the first 2 questions, did you want to explain anything more, or did we get everything?
Got it.
All right. So, I want to ask you one more thing. Again, I think I might have said it. I'm just going to reiterate it. How did your didactic curriculum impact your confidence?
It made me realize that I knew what I was talking about. So it did help. I was able to spit out information asked, things that I saw, with a patient, maybe the way a patient presented. I was like, oh, we learned this, or, these are the clusters of things that you learn in school. Like, for example, somebody has pain when they bring up their arm up here, but then, and then they're talking about if they reach in. So I'm like, oh, that's impingement. So, stuff like that, I feel like the school really helped me. Does that make sense?
That makes perfect sense. That makes, definitely sense. All right. Excellent. All right. Number 3. All right. Tell me about the areas of your curriculum that prepares you for your rotation. You already mentioned one, but can you reiterate that?
So I think clinical skills definitely helped, because that was just the barrier of, that broke everything. That taught us everything. We learned, range of motion, muscle testing, basic joint mobs. I still wish we had learned maybe more intense ones, but that's what continuing ed is for. Obviously.
True, yes.
So I felt good with that. Going over cases cardial pulm and neuro. I feel like neuro, it was cool to go visit the hospitals, but I would love to actually have worked with a neuro patient, because now if you were to give me a neuro patient back then, I wouldn't really I would feel nervous, because they're more complex and they have a lot more going on than an ortho patient. Musculoskeletal class for ortho, that did help, but then again, I think it depends on who teaches, because something that people have said, it seems like some professors teach what they believe in, or they'll will go by what they say is right or what they believe is the best thing, but it might not be the best thing. Not that it's wrong, but one professor can say, oh, Mackenzie is the best way to go always, but then you can go out and talk to another professor and they say, well, sometimes Mackenzie doesn't work.
So you felt, again, that some of your musculoskeletal components or the ortho components was kind of biased and only showed you just one highway, but not everything.
Yeah, because I feel like there were some things that we didn't learn, certain functional tests. Maybe a professor didn't think it was necessary to teach that.
Okay.
So
you're saying, just to reiterate, you're probably saying that you thought, or not that you thought, but you wish that you learned more of a general sense rather than just this narrow-minded view of something, or this narrow-minded theory of ortho.
Yeah.
Okay. That's good. Again, how did your learning experiences in your curriculum help you with your decision making and skill level during your clinical rotations?
Let's see. Well, first of all, I feel like precautions, that helped. That was one of the first things we learned. So I feel like that really helped. What did you ask again?
Oh,
how?
Yeah. Okay. No, it's it's kind of what you said, but I just want to reiterate it. Is how did the learning experiences in your curriculum help you with your clinical decision making and skill level during your
So yeah, going back to like I guess taking a subjective history,
Mm-hmm.
I was able to already think about before I even did an objective, like think about what I wanted to do based on their presentation, and I feel like case studies were helpful with that, and just learning like all the special tests and what they're tested for, like based on what symptoms. So I feel like we were strong in that.
Good, good. Did you feel like it helped you with your like hypothesis generation? You know, thinking about what I got from this subjective component, I could give myself a hypothesis list, and now I could use my
Yep.
objective test. Okay,
Yep, I
that's
definitely
good.
feel like that helped.
Good. Yeah, I do kind of feel that sometimes they don't. Some areas in school because you look up to your professor and you trust your professor, and basically whatever the professor says, all right, is from a student perspective. It's
Yeah.
like that's the
It's the
only.
Bible,
It's
yeah.
the Bible.
Yeah.
Yes. Do you feel that the where did you feel that was that more of every kind of case with your didactic curriculum, that is the professors taught you this is the Bible and you got out into the real world and it's like, well, it really isn't. Can you explain more
No,
about
I mean,
that?
I feel like it was just the one instant in the one musculoskeletal class.
Okay.
But like, cardiopulm, it's hard to teach cardiopulm because it's people's hearts and different things. Like,
Mhm.
everyone is so different than each other. So, I feel like I was prepared with that, but I'm also not really seeing cardiac rehab.
Yeah.
Neuro, they gave us the basic. So,
Mhm.
obviously, again, too, no brain injury patient is going to present the same. So, I mean, I don't know how they would have taught like one way. We
Yeah.
learned the basic way. So I felt okay with neuro. I think it was just the musculoskeletal.
Okay.
And like I said, I think it
Yeah.
just depends on who teaches it.
No, I do agree, and that happened to in most schools because
Yeah.
musculoskeletal is so general.
Right. And it's like whatever
And whatever
they
the teacher.
specialize in.
Yeah, I understand that too.
Like, I don't really like to do manipulations. That's something I've really realized as a clinician. I just don't feel comfortable doing them. Maybe because I don't really know them that well.
Okay.
But that one class was full of manipulations, and I was like, oh, I hate this, because I wasn't that great at them. But
Yeah.
it could be just because I'm not that great at them, or
I don't think
don't know.
so.
Yeah.
Manipulations is a higher skill
Yeah.
level, but it's more of knowing what to do and the precautions of it, explain
Yeah.
to the patient. All right, but also too, you have to be comfortable doing them.
Yeah.
And it takes a very high psychomotor component to perform.
Right.
All right. One thing I think you mentioned, and that this could still be some of your question 3. I think you said that you kind of during your clinical rotations, like you didn't get to see everything.
Mm-hmm.
All right. Like such as I didn't get to see an ACL.
Yeah.
All right. Did you learn how to treat some of those patients, like an ACL or let's say anything in your didactic curriculum that you did not see, but did you still feel confident that if
So-
you get an ACL tomorrow, you're confident to do it?
So that was going to be, I was going to talk about the next question, but I don't know. Like, I know the basics, but we had to do a project for us. Like, we just had to, like, each group had to write the protocol of a surgery. But when it came to treating it, like, when I saw my first rotator cuff patient and they were in the sling and I had to take their arm out, I was like, oh my God, like, I
Yeah.
don't want to break them kind of thing.
Okay.
So I feel like,
So
We
you
were
had
prepared
it.
with
So you
that.
had it all on paper.
yeah.
So it looks good on paper.
Right, but
Like the
then
team
when
looks good on paper, but once they actually go
Yeah.
in, yeah.
So that's definitely how I felt
Okay.
with that.
All right. No, that's good to know. So, question 4. All right, you can say the same things again. Talk to me more about the areas in which you felt deficient in your more of your didactic curriculum.
So my main thing too was post-surgical. I still feel like I haven't seen a lot of post-surgical now working for 2 months, but I guess that will grow. I felt very unprepared with that. For example, I remember saying one time, we learned in school only to take range of motion of the shoulder in 90 degrees of abduction. You get a shoulder post-surgical patient,
Mhm.
and my CI was like, "Well, do it in 0 degrees," and I was like, "What does that mean?" And I'd never done it before. Like I've only known this. So and then I had to. Another thing too was physically taking the person in and doing like passive and measuring at the same time. That was difficult. I usually had to ask for help because holding the person's arm and then getting the goni and setting it, I feel like I needed 3 hands.
Yes. So to reiterate what you're saying is, you felt what you learned in school did not apply to.
Yeah.
So
Especially
some of the for post-surgical things that you learned in school you couldn't replicate in the clinic.
Right.
Okay. No, that's good.
Same
Continue.
thing, multiple body parts. Like I feel like a lot of things is person comes in with knee pain, but then in the real world you're seeing knee, back, and hip.
Yeah.
Or like ankle, neck, and
Some psychosocial components.
Yeah. So I mean, I think just dealing with that, and then I'm gonna tie that to time management. So yeah, in school, we don't learn how to keep an eval within an hour, for example. We don't know how to deal with the time management of getting your subjective, objective, giving a patient their home exercise program, helping them, explaining their prognosis and, what you found, all into an hour per se.
Yeah.
So I feel like that, and then involved with the multiple body parts, like our brains are scattered, you gotta think of all these things.
Yeah.
So I feel like I had to eventually get the clinical reasoning to see what was best for me to test at that moment. So like, in school you might learn 100,000 things you can test, but then I had to judge what is important at that time with the multiple body parts.
Gotcha. So just to reiterate, is like you understood what to test, but you only had a certain time, so you had to choose the best or what is most effective or what you're going to give out.
Right, or like what you think would make a difference or matter in the eval. Like if you just doing a test for the heck of it because it's a back test, like why waste time? And if you don't think it has to do with the presentation of the patient.
Exactly.
So that, and what else? Time management, also like 2 patients at once. I know in school, like they don't really tell you that whole thing about your full, you're going to see a full caseload.
What do you mean?
Like, I totally didn't think about it until I started working here, like as an intern.
Yeah.
More like, wow, I'm going to see like 15 to 20 people a day. And then getting 2 people at a time, dealing with that time management. Because like in the beginning, I was just working on, okay, what's this person do, how to treat them, and how to get them to like me and do it. And then you have another person coming in, and then you're still trying to do everything with this person. So that comes in clinic. I feel like maybe they could have just given us tips on what to do, or how to act. Like when you're doing manual with one patient and then another patient, you tell them, okay, like, let's put you on the bike instead of having them sit there. Like maybe giving us like tips with that. I know there's not much they could have done, but I felt like really nervous with the time management in the beginning. And then my last one point too is everyone is healthy that we work with. Like, I have an ankle issue, so like maybe my range of motion sucked compared to, my classmate, but that wasn't like a severe deficit.
Yeah.
So with that.
So it was difficult for you at times to, again, treat injured people and seeing that for the first time and how they are completely a 180 from Chinese regular.
Yeah, definitely. Yeah. And another major thing that I still don't feel confident in but like I'm looking things up and reading, functional tests. Yeah, we learned like 6-minute walk tests. We learned, the tug and that stuff, like more balance. But I feel like I had a PCL patient and my CI was like to me, well, what's a functional test you can give him? And I was like, I have no idea. So I had to go look in the book. And
5 times to stand?
No, it was like the HOP test. He wasn't post surgical.
Okay.
But like he was highly functional.
Okay.
So I looked up the HOP test and I was like, oh wow, like I wish I had known that. But we didn't really learn any of those tests. Apley scratch test we didn't learn. I swear to God. My CI,
All right. We did do that, but it wasn't enforced.
Okay. Yeah.
It was kind of that one point in the chapter that was in the back. It's like, this is the alternative way.
Okay. So, I don't know, maybe some, like, I guess, like, some other functional testing. Like I feel like we focused so much on balance tests that we didn't do
Okay.
like other body parts.
So you kind of missed out on certain patient populations
Yeah.
that have these deficits where you were only limited, where you felt that you could have had more of this.
Right. Like I did it like, in the beginning with that kid, for example. I could have done 5 times sit to stand, but now this kid is so much better. What am I gonna? I'm not gonna give him something that's
Yes.
more for somebody who's weaker, maybe older,
Okay.
or more acute. But now the kid was
So for the advanced clients, you kind of didn't know what are the functional tests to perform
Yeah.
for. Okay. No, that's very reasonable. All right. So like again, like what would you change about your curriculum to like might have prepared you like a little better?
I really wish we had either more site visits or like patients coming in to
Okay.
see us, like, and then maybe us working with them more and having a professor oversee us. Like, yeah, we did it a couple of times, but I feel like we were all in a big group, and maybe that therapist was there, but it was like easy stuff. Like I feel like to be more realistic, I really would like to have gotten the opportunity to see like a really crazy intense
Okay.
patient and maybe like think of things to do with them and then we do it with them. Like yeah, we did do a little bit of it,
Yeah.
but I feel like we needed more of it.
Yeah. I agree. Anything else that might have,
I know there's not too much they can do, but when it came to billing, I knew nothing when I came into the clinic.
really?
We all were confused by it because like we had that class, but like I mean the unit stuff, yeah, I get that now, but I don't know. It was just always very.
Okay.
Like, Ryan had to help me with
yeah,
that.
so you had a class on it, but you just felt that it was insufficient
Yeah.
for you to use it in practical sense.
Yeah.
Were you-
Because we were just learning about it. We weren't doing
Okay.
anything. Like
Yeah.
maybe if we had like classwork or she did examples like
I
this
see.
unit like these units and this and whatever
or something where they gave you a project where it's like, okay, you did A, B, and C, and D.
Yeah.
How are we going to build this?
Right.
So more of a, I
like
would
what
say,
to name it,
like,
NRX, NR, TE.
yeah, or
TA.
maybe doing like a problem-solving
Yeah.
based solution. Okay, gotcha. Or case-based solutions for building.
Right.
Okay.
Yeah.
Gotcha.
What else would I change? Add more post-surgical stuff, like the complex patients, because post-surgical patients are not cookie cutter.
No.
Everyone has different reactions to things.
Yep.
A post-surgical shoulder is not going to be the same thing as a patient with shoulder impingement.
Yeah.
So when you're testing range of motion, or you can't even do muscle strength on a post-surgical shoulder,
Yeah.
you know what I mean? So
How did you feel? Sorry to cut you off again. How did you feel about learning about more of those psychosocial patients or those pain dominant patients? How did you learn more about that in that's the curriculum, or did you learn that more in your clinical rotations?
I kind of I guess more just in rotations, I kind of adapted. Like I'm an empathetic person.
Yeah.
So I feel like I was
You
just
are.
trying to really just be there for the patient.
Yeah.
Like they didn't really need to tell me that in school, but maybe other people do.
Yeah.
Because like we at orientation today, the one person was saying that they had to learn how to be empathetic. It's not that they didn't care, but they needed to learn to